Today I'm going to discuss NEET PG 2022 questions from Medicine and Pediatrics. We'll be doing this in two parts. Apart from telling you the answers, I will also giving you the references and touching the topic very briefly so that you can answer questions coming from the same topic easily. So let's begin. The first question is, a patient with acute onset of stroke developed while flinging proximal ballistic movements of the limbs on one side. What is the likely site of lesion? Here, look at the keywords. These flinging proximal ballistic movement happening on one side. So what he is having is hemibalismus, and the most common site of lesion in hemibalismus is subthalamic nuclei. So this is the answer. You can see the reference over here. Now the important thing about hemibalismus that you should remember is that it involves proximal muscles mostly, and it's a large amplitude flinging type of movement. Now the lesion, as you can see, it is most commonly in subthalamic nucleus, and the drug which is useful over here is dopamine blocker drugs. Apart from hemibalismus, you should also be aware of some other movement disorders like dystonia and acidosis and chorea. Now dystonia, how will you identify dystonia? In dystonia, what happens? The agonist and antagonistic muscles both contract at the same time, leading to abnormal posture. So abnormal posture is very important over here. In acidosis, what happens? The movements are slow and rhythmic movements, and it tends to involve the distal muscles of arms and hands especially. So in chorea, what you should remember, the movements are more rapid and they are dance-like and graceful movements. Now the lesion in case of dystonia, mostly you can see dystonia in a number of diseases like Wilson's disease. Apart from that, a lot of genetic diseases do have dystonia. In dystonia, the common thing that is affected is basal ganglia, and especially the putamen. And it has been seen that deep brain stimulation of globus pallidus can relieve dystonia. Relieve it. Now in acidosis and chorea, they coexist. In acidosis, also the site of lesion has been found to be basal ganglia. The chorea, you can the most common choreas among the common choreas is Huntington's chorea or Huntington's disease. And in Huntington's disease, the part of the brain which is affected is actually the striatal area of the basal ganglia. Now coming to the next question, a patient with recurrent chest infections, abdominal pain. He presented with a history of one blood transfusion in the past. On examination, he had icterus, mild splenomegaly. Electrophoresis was done, which showed HbA2 increased, HbF increased, and S spike. What is the most likely diagnosis? So diagnosis is very clear, but to tell you something that the patient actually is presenting with signs and symptoms of hemolytic anemia. As you can see over here, the patient had a transfusion in the past. Apart from that, he had jaundice and mild splenomegaly. Now, what kind of hemolytic anemia might have recurrent chest infections and abdominal pain? So from this part only, you can deduce that the most likely hemolytic anemia in this case is going to be the sickle cell anemia. And after that, they gave the electrophoresis report, so made it very clear. So the answer is sickle cell anemia. Sickle cell anemia patients have a lot of complications, and it would be wise to remember those complications because a lot of questions could be asked, indirect questions could be asked from this topic, which can be related to the complications. Now I will take you through the complications. In sickle cell anemia is a single gene disorder. What happens here that the thymine comes in place of the adenine, resulting in the change in the beta globin gene. So what happens in the amino acid, the valine replaces the glutamine. Now these are the complications. I have summarized them over here. You can see that these patients are prone to develop bacteremia. What happens? Their spleen becomes functionally non-functional. Actually, they become functionally asplenic by the age of 5 years usually. And because of that, they are prone to develop a lot of infections by capsulated organisms. So the capsulated organisms are the common infections are Hep, meningococcus, and pneumococcus. So these patients are prone to develop infection by these organisms. Apart from that, you should also remember the osteomyelitis in these patients is by E. coli or Staph aureus. Both can cause in these patients osteomyelitis. So bacteremia presenting with fever and any focal infection, they can be an important presenting symptom of sickle cell disease. Apart from that, aplastic crisis, usually due to parvovirus infection. Now, how can you differentiate aplastic crisis from the anemia happening because of the sickle cell disease itself? Is by the help of this reticulocyte count. In sickle cell anemia, as such, the reticulocyte count, the corrected reticulocyte count would be high, while in case of aplastic crisis, the reticulocyte count would decrease. Now, in splenic sequestration, what happens? The patient suddenly develops a decrease in hemoglobin, and the blood gets trapped in the spleen, resulting in increase in the size of the spleen, leading to abdominal pain in the left quadrant. The patient could also collapse. Then all the hemolytic anemia patients are prone to develop gallstones. These patients are very prone to develop the sickle cell pain crisis, or hand, in which especially the hand and foot are involved, leading to swelling and painful swelling of the hands and foot, which is called hand-foot syndrome. Then avascular necrosis is also an important complication. It affects usually the femur head. Apart from that, it can also affect humeral head and mandible. Priapism is also an important presentation of sickle cell disease. CNS involvement is also very important because of these patients could land up into stroke, and rarely they can also develop cerebral venous thrombosis or this posterior reversible encephalopathy syndrome. Fat embolism has also been seen, and fat embolism, actually the fat comes from the infarcted bone marrow, which can present with pain, respiratory distress, and altered mental status with multi-organ dysfunction. Their respiratory symptoms are also very common presentation in form of acute chest syndrome, in which the patient develops fever with respiratory distress and hypoxia. You should remember these three. Your X-ray, if you will do, you will find a new radio density. This will help you to pinpoint that the patient has developed acute chest syndrome. Renal disease is also common in these patients. It can present in variety of forms, nephrotic as well as nephritic. And one carcinoma that you can remember is renal medullary carcinoma. These patients are prone to develop renal medullary carcinoma. Apart from that, even eyes could be involved in form of sickle cell retinopathy. Leg ulcers could be there. There could be delayed puberty. The treatment, apart from the regular blood transfusion, is adding hydroxyurea, and the final treatment is stem cell transplantation. Now coming to the next question. A patient presented with chest pain and palpitations to the emergency. ECG shows the following. Blood pressure is 120/70. What is the next step of management? Now over here, as you can see here, the rate that we can calculate is by 1500 divided by small squares, or 300 divided by the large square. You can see here that the rate is coming to be approximately 300, so the rate is very high. Now, apart from that, you can see the QRS complex is also very wide. So this is basically the patient is having ventricular tachycardia. Now, there are certain ECGs that we should be able to recognize just by, inspection only. Very easily you should be able to recognize certain ECGs. So I have summarized them over here. This is the ECG of proximal supraventricular tachycardia. Here, this is, you can see classical ECGs of PSVT. Next, this is the ECG of atrial flutter. You can see a lot of P waves not continued by the QRS complex. So this is atrial flutter. Here you can see it is the ECG of atrial fibrillation. The P waves, as you can see, very hardly recognizable. Now coming to the ECG of ventricular tachycardia. This is a monomorphic ventricular tachycardia. You can spot the ECG over here. The ECG is, this is the ECG of monomorphic ventricular tachycardia. Because of this, you will save time if you remember the ECGs also. Now this is the ECG of ventricular flutter, and this is totally chaotic ECG. This is a ECG of ventricular fibrillation. And the drug of choice, when you have to use the drug in all kinds of ventricular arrhythmias, is usually amiodarone. And in case of life-threatening conditions, you have to give it intravenously. So the answer to our question was intravenous amiodarone. Now coming to the next question. A patient presented with anorexia jaundice, right upper quadrant abdominal pain. Investigation showed HBs antigen positive, anti-HBs antigen negative. IgM anti-HBC was positive. What is the likely diagnosis? It's very clear. HBs antigen positive makes the patient infected with hepatitis B. Now, IgM anti-HBC positive makes the patient having acute hepatitis B. So this is the answer. Now, it would be wise if you remember this chart. It's not very difficult. I'll summarize it. I'll tell you in a very easy manner. Now look, HBs antigen is positive only in 3 cases. If very early in the infection or very transiently after we give a vaccine. Okay, so HBs antigen would be positive at that time. So in acute infection, you have HBs antigen is definitely positive. In chronic infection also, HBs antigen is also positive. Now look at this anti-HBs. Anti-HBs would always be negative when HBs antigen is positive. It's always negative. When the HBs antigen is positive, when the patient is having the infection, anti-HBs is going to be negative. Okay. Now look at this IgM anti-HBC, and it is also positive only in 2 cases. This is acute infection. If anti-HBC IgM is positive, then you have to suspect acute infection. Okay, or of course acute resolving infection. So in case of acute infection, it would be positive. When anti-HBs becomes positive and all the others are negative, the patient is considered to be immune. Okay, considered to be immune. If he is not having any other antibodies positive, only anti-HBs is positive, then he is immune because of the vaccine. And if the anti-HBs is positive and along with it total anti-HBC is positive, that means he is immune, but he has recovered from the past infection. He is immune because of the infection itself. Okay, so it's not very difficult. By this chart, you can easily remember how to interpret the test results of hepatitis B infection. Now coming to the next question. A patient presented with complaint of fever, sore throat, cough pain since 1 week. On examination, he has jaundice, subconjunctival suffusion and tender hepatomegaly. He has good urine output. No history of travel, no history of chills, rigors and anorexia. What is the most likely diagnosis? Here you can see the keyword is subconjunctival suffusion. Now with tender hepatomegaly. What patient is having is actually he's developing wheel syndrome, which is seen in leptospirosis, which is a complication of leptospirosis. Now I have summarized the features of leptospirosis in one chart here. You can see leptospirosis, as you already know, it is caused due to leptospira, which is a type of spirochete. It enters into the body through mucous membrane, which can be eyes, nose, mouth, or even by ingestion of water which is contaminated with rat's urine, or it can enter through the abraded skin as well. Now the clinical features, the characteristic clinical feature about it is that it causes disease in 2 phases. It's biphasic infection. The symptoms appear in 2 phases. There might be a period of asymptomatic stage in the middle of it. Now in the first phase is basically flu-like symptoms. Well, the patient will have a fever along with headache, malaise, body ache, myalgia. And after that there will be a short asymptomatic period, and after that some patients develop immune phase in which a lot of organ systems are involved. Patient might develop jaundice by the involvement of liver, or he can develop renal dysfunction, he can develop bleeding tendencies, pulmonary hemorrhage and cardiovascular collapse. So this in the immune phase, patient becomes really toxic or very sick. Now this wheel syndrome, this is called as wheel syndrome, in which the patient develops jaundice along with renal dysfunction, thrombocytopenia, pulmonary hemorrhage and cardiovascular collapse. But most of the patients in the immune phase, they develop the features of aseptic meningitis along with uveitis. Another thing that you can remember is that in the first initial septicemic phase, which is called as, in the first initial phase of infection, you can recover the spirochete from blood and CSF and tissues. While in the second phase, the organism hides inside the organs, and then you can only detect the infection by the presence of antibodies, which is actually considered to be the gold standard for diagnosis. Gold standard is microscopic agglutination test, but it is only positive after 12th day of infection. Here, during the first 10 days, you can isolate the organism in blood and CSF. After 10 days, you can still isolate the organism. It is found in urine. You can still find the organism in urine and aqueous humor. You can remember that. aqueous humor in the eyes. Now the treatment is for this is penicillin G. You can also use ceftriaxone, doxycycline or azithromycin. Now coming to the next question. A patient presented to emergency, ABG was done and showed the reports pH 7.2, PaCO2 80, bicarbonate of 35. Which of the following acid-base disorder is present? So the question is not very complicated. They have asked a very simple question, but you can answer this only if you remember the normal values. The normal pH is 7.35 to 7.45. Normal bicarbonate is 20 to 28 milliequivalents per liter, and normal PaCO2 is 35 to 45 millimeters of mercury. So in our patient, as you can see, the pH is less, so he is definitely having acidemia, and the process which leads to acidemia is called acidosis. Now look at here, if the patient will have metabolic acidosis, then his bicarbonate would be low, because body produces a lot. When the body produces a lot of hydrogen ions which causes acidosis, then that hydrogen ion combines with bicarbonate, leading to decrease in the bicarbonate level. But in our case, the bicarbonate level is not less, in fact it is a little high, but the thing which is high is PaCO2. So when PaCO2 increases, it is an acidic gas, you can say, so because of which the pH decreases. So it's clear-cut a case of respiratory acidosis. Now coming to the next question. A diabetic person who recovered from COVID months back now develops severe hemifacial pain predominantly in the jaw, and one of the teeth has become loose. Next step of management is, so as we all might have read, COVID patients in India especially were prone to develop a complication called mucormycosis. Now the type of mucormycosis which was most prevalent in India was rhino-orbitocerebral mucormycosis. So in this patient, we are worried if the patient has developed ROCM or not. So how will you identify if the patient has developed ROCM? Because this is with this disease had very high mortality. So we had to identify if the patient was having that or not, was with the help of radiological imaging. So all those patients were underwent MRI or CT imaging, so as to identify the stage to which the disease has infiltrated inside their brain, and so that the earliest treatment could be started. So these patients would go for MRI brain. Now you will be very interested or surprised to know that the most common fungus associated with COVID-19 was not actually mucormycosis, it was actually Aspergillus and Candida. But mucormycosis was the thing which gained a lot of attention, especially in India, because in India it had the highest, you can say the burden of mucormycosis in COVID patients was highest in India only. There are certain risk factors to which predispose a patient to mucormycosis. This is mostly uncontrolled diabetes and hematological malignancies, which is mostly seen in the pulmonary mucormycosis. Now, the treatment which we gave in mucormycosis was amphotericin B. Okay. Coming to the next question. 7-year-old child presented with palpable purpura, arthralgia, pain abdomen and melena. Which of the following is used in the treatment? Now look here. Palpable purpura with arthralgia with pain abdomen. So this is already pinpointing the diagnosis to be Henoch-Schönlein purpura. Henoch-Schönlein purpura is the commonest childhood vasculitis. Now, in these patients, most of the patients recover on their own. But when their GIT is involved, like in this case, patient is having melena, in those cases, we have to use steroids. So the treatment of choice is steroids in this case. Now, I have summarized Henoch-Schönlein purpura here in one slide. You can see here, it is the most common vasculitis, or it is a leukocytoclastic vasculitis, or also called as IgA vasculitis because of deposition of IgA in tissues. Now, it affects children in the first decade of life. Clinical feature is rash along with arthritis or arthralgia. GI involvement is also there, renal involvement could be there, and CNS involvement could also be there. Diagnosis is mostly clinical. If you do a CBC, what you will find is thrombocytosis, okay, or platelet count can be normal also. Apart from that, there can be mild anemia and ESR would be elevated. Now the treatment is, it is self-resolving. Remember, steroid is only used in case of GI involvement or life-threatening issue. In case of nephritis, you have to use you might have to use azithromycin azathioprine, cyclophosphamide, cyclosporine, or mycophenolate mofetil. Now coming to the next question, which is 11-year-old patient with fever, polyarthritis, had a history of sore throat 45 days ago. Very, very, direct. It is directing us towards something which is a complication of sore throat. So you know what it could be. It could be a patient is developing rheumatic fever. Investigation showed throat swab is positive for streptococcus. Raised ESR is present. However, on echo, there was no valvular disease and no features of carditis. So it's very relieving that he had no features of carditis. No past history of RHD is present. Prophylaxis is recommended with benzathine penicillin injection 6 lakhs units every 3 weeks for how long? So it's very easy if you have to remember just one chart. And the chart is also very simple. When there is no cardiac involvement in rheumatic fever, then also you have to give prophylaxis, but it would be only for 5 years or 21 years, whichever is longer. Okay, so you can remember it, 5 years. Here, if there is cardiac involvement, but it is not leading to any chronicity, it is not leading to any valvular disease, then you have to give it for 10 years or 21 years, whichever is longer. Okay. Now, if the patient has carditis, which has really, it has developed into a valvular disease, then we will have to treat the patient till 10 years or 40 years or lifelong. In some patients we have very severe involvement of the valvular, which have all the patients which have very severe valvular disease. In those patients, we might have to give it for lifelong. So this chart, if you remember, you can easily solve questions related to this. The without cardiac involvement, 5 years. With carditis but no residual heart disease, 10 years or 21 years. With carditis and residual heart disease, 10 years or until 40 years, whichever is longer. Now coming to the next question. A patient with chronic liver disease developed ascites. So in this case, the answer was 5 years. A patient with chronic liver disease developed ascites with diffuse abdominal pain. Ascitic tap showed 600 polymorphonuclear neutrophils per microliter. What is the most likely diagnosis? So patient of CLD with ascites developing neutrophils in his ascitic fluid. So its answer is very clear. It is subacute bacterial peritonitis, which happens to be a common complication in case of ascites. This is the reference you can see here. It is from Harrison. Now, things that you should remember here is that a diagnosis of SBP is made if the neutrophil count in the ascitic fluid is more than 250 per microliter. The common organism is E. coli. Apart from that, other bacteria can also be involved. If there are 2 organisms, then the perforation is also suspected. Okay, if you isolate 2 organisms, then perforation is also suspected. So now coming to the next important topic. A patient presented with features of meningitis. CSF shows increased protein, mild decrease in glucose. CSF image is shown below. What is the most likely diagnosis? Here you can see there is a Cobb wave formation happening. So we all know that Cobb wave formation is seen in tubercular meningitis. So the answer here is tubercular meningitis. Coming to the next question. Coming to the explanation here, you should remember this chart. This chart is very helpful to solve the questions related to CSF findings. Now look at I will just tell you the cardinal things. Now in acute bacterial meningitis, the main thing is that the WBC is very high and it is predominantly neutrophilic. Okay, the sugar would be very low in CSF. It can even be 0. Okay, the protein is up to 100 to 500 milligram per deciliter. In case of tubercular meningitis, the WBC is up to 500 only, but it is lymphocytic and the protein is very high here. Protein is very high. The sugar is less, but it is not as less as in bacterial meningitis. In case of viral meningitis, the interesting thing is that WBC is also increased, but it is not very much increased like septic meningitis, and it is mostly lymphocytic. Protein is also increased moderately, but the glucose is normal. The interesting thing here is the glucose is normal. In partially treated meningitis, this can sometimes appear to be like viral meningitis, but here what you have to notice that the sugar can be normal to decreased and the protein is also high, as well as the counts might be in any range from 5 to 10,000, and it can be initially it can be neutrophilic, and later in the treatment course it can be lymphocytic also. So you can remember this chart, which will make you easier to solve such questions. You should always remember the normal values, because then only you can identify the abnormal. The normal pressure is less than 28 centimeters of water. WBC normally is less than 5 and it is lymphocytic. Protein is 20 to 45 milligram per deciliter, and blood sugar, CSF sugar is more than 50 milligram per deciliter, or at least more than 75% of the serum glucose. A patient posted for hernia surgery complained of fatigue. ECG shows depressed T wave with ST segment depression and U waves. What is the most likely diagnosis? So we all know that this has to be hypokalemia. We should remember some of the ECG features, especially of electrolyte imbalances associated with potassium. Here you can see, I have summarized it here in one slide. Hypokalemia causes flat T waves, appearance of U wave apart from ST depression and QT prolongation. Hyperkalemia causes T wave peaking. Apart from that, it causes flattening of P wave. And there can be, in late cases, there can be sine wave pattern leading to ventricular fibrillation. It is seen in hyperkalemia. In hypocalcemia, there is QT prolongation. In hypercalcemia, there is bradycardia. Apart from that, there can be AV block, and shortening of QT interval is seen. In hypomagnesemia, the T wave is flat. ST lengthening could be seen. In hypermagnesemia, there is prolongation of PR, QRS and QT everything, and there can be a complete heart block. So this is a memory-based question. You have to remember the ECG features in different electrolyte imbalances. Coming to the next question, which is also very simple. A patient presented with deviation of angle of mouth to right, drooling of saliva, unable to close left eye. So where is the lesion? The lesion is obviously he is having facial nerve palsy, and which side is affected? Obviously the left side. He is not able to close the left eye, and his mouth is deviating to the right because his right side is functioning normally. So he is having left facial nerve palsy. Coming to the next question. A patient presented to emergency with palpitations was found to have irregular pulse with a pulse deficit of 20. JVP will show what? Now look here. Patient is having irregular pulse. Along with that, they have given pulse deficit. So this is the characteristic feature of atrial fibrillation. And in atrial fibrillation, we all know that what you will find in JVP, it would be absent A waves. You can answer this question very easily if you remember the two things. First is that what is the features that we see in atrial fibrillation, and this is the reference. You can see irregular rhythm is usually seen in atrial fibrillation. Apart from that, you can also find it in ectopic beats or self-limiting paroxysmal arrhythmias. Now, pulse deficit, as you can see, it is also seen in atrial fibrillation. Now, these are the waves of JVP waves. See, it's very important to remember which wave is caused by what action. Now, A wave is because of atrial contraction. C wave is because of the closure of tricuspid valve and ventricular contraction, and V wave is because of venous filling. Now, these are the common questions that are asked associated with the waves of JVP. Absent A waves in atrial fibrillation. Large A waves is seen in pulmonary hypertension, pulmonary stenosis. Canon A waves is seen in complete heart block, ventricular arrhythmias and ectopics. Large V waves are seen in tricuspid regurgitation, and small sign is seen in constrictive pericarditis. These are the common questions that I have summarized them over here.